Hi, everyone. Good afternoon, good morning, wherever you happen to be. Welcome to the Les Turner ALS August, my goodness, time is flying. August ALS Learning Series here. I'm just going to share my screen. I just want to remind you all that you are off camera and muted so you can sit back, relax, and enjoy the presentation, which should take about an hour. I'm Anne-Marie Doyle. I'm the Community Education Manager here at the Les Turner ALS Foundation. Before we get started, I just want to do some thank yous. So we want to thank our generous partners, the Gilbert and Jacqueline Fern Foundation, and our industry partner, Mitsubishi Tanaba Pharma America. Without their support, this wouldn't be possible. If you're interested in learning more about ALS, please visit our website at lesturnерals.org. That's where we have our online decision tools to kind of support you through different decisions that you may need to make. We also have some in-depth information about ALS symptoms and care options, or you might just be interested in learning more or watching past ALS learning series. This can all be found on our website. We are also hosting a Les Turner Symposium on ALS. That'll be Monday, November 4th. We'd love to have you in person in Chicago, but it's also virtual. If you just scan that QR code, that'll take you up to our registration page, or you can learn more at lesturnерals.org/symposium. And then lastly, if you are interested in joining the National ALS Registry, learning how you can, make your voice heard or participate in clinical research, you can learn more at cdc.gov/ALS. All right, so now it is with great pleasure I get to introduce you to two incredible people in the ALS space. Dr. Mehta is an associate professor of palliative care at the Departments of Medicine and Neurology at the Johns Hopkins School of Medicine. She graduated from the internal medicine residency at Johns Hopkins Bayview Medical Center and hospice and palliative medicine fellowship at the National Institutes of Health. She is currently part of the palliative care faculty at Johns Hopkins and developed the palliative care program in the Johns Hopkins Center for Specialty ALS Care. Before this, she was an assistant professor of palliative care at the University of Virginia and medical director of the UVA Hospice of the Piedmont Inpatient Hospice Unit and the University of California, Los Angeles, where she also developed the ALS palliative care program as part of their multidisciplinary ALS clinic. And Dr. Makowski is currently the medical director of Compassionate Care ALS, a nonprofit group that supports patients and families living with ALS throughout the United States. She's worked as a palliative care physician in various academic and community settings, as chief of palliative medicine at both Unity Hospital, Exeter Hospital in New Hampshire, co-chief of palliative care at UMass Medical Center and Chan School of Medicine, where she still holds a voluntary associate professor of medicine role, teaching and mentoring students, and as a hospice medical director at Hospice and Palliative Care of Cape Cod. She has served on various committees, including on the board of the New Hampshire Home Care and Hospice Association, End of Life Council to the Massachusetts Department of Public Health, and Quality Committee of the AAHPM. She completed her fellowship in palliative care at San Diego Hospice and Palliative Care and Integrative Medicine at the University of Michigan, internal medicine residency at Bay State Medical Center, and the medical school at the University of Rochester. Welcome, welcome, welcome. Without further ado, I will kick it on over to you. I'll stop sharing my screen.
It says I do not have access to share my screen.
Good grief.
Sorry about that.
No, so sorry about that. How about now?
I do now. Thank you.
Okay, great.
So let me get this up. Can you see those slides?
Yes, that looks great.
Excellent. Okay, great. So thank you so much for joining us today. I think this is one of the most, for me personally, I think I am very, very excited about this conversation because a lot of what we do is, I'm in an academic center. I train a lot of learners coming through in terms of discussing uh, topics and how to care for your patients. Uh, and I think it's really important that, they understand, of course, what we're trying to teach. But on the flip side, if we can kind of reveal the, Wizard of Oz a little bit and pull the curtain back and share with you, what is it that we as clinicians and practitioners are teaching each other, learning about each other, and then about how to take care of patients and care partners, it might give a little bit more of a two-sided conversation, a two-sided understanding to the needs that we're trying to address. And the way to do that is really to help share a little bit about, how we're trying to, how I think as the healthcare team, we're trying to empower patients and care partners to engage in conversations, whether it's about, palliative care or hospice or end of life, or just from the very beginning of diagnosis and all the way through their disease, even if you don't have a palliative care or a hospice specialist involved, how to interact with your neurological teams and your speech therapists and, anybody in the healthcare, team that is helping you, because you are the ones, patients and care partners are the ones living with these diseases. So you know this better than any of us. We really are hoping that this comes to, that you kind of feel more like this is coming away as coaching and thoughts and we hope that we can be more interactive with conversation at the end. But really the questions that we are coming at you with today are, how do we get, how do we as human beings share the right information to each other, right? How do patients and care partners share the information that their doctors and healthcare teams that you need them to know, and vice versa, of course. How do the healthcare teams share information to you all? But really the focus today is about how to make sure that you're getting the information that you need to across to your care team. And it's not just about what do you want medically, it's really importantly about how do you want to live? How do you want to be with this new state that might be presented to you or that you've been living with but has now changed, as ALS and neuromuscular diseases make every day a little bit uncertain. How do you live with that? And, in palliative care, our focus is about helping people keep their personhood instead of just being a person with ALS. And that is really the focus of all of palliative care. That's why you have two palliative care doctors here today with you, because that is really the intention of palliative care is helping people live. It's not just about helping people at the end of life. So, we want to make sure that you feel like you are heard and understood at the end of your conversations with your healthcare teams. So we'll want to share a beautiful quote by David Augsburger, who was he's this amazing social worker and a theologian. He said, being heard is so close to being loved that for the average person, they are almost indistinguishable. And I think that that's something that really fuels at least the hearts of palliative care practitioners, but a lot of but hopefully a lot of you all as well. So through our conversation today, our hope is to explain why self-advocacy is important, to describe serious illness conversations as one form of self-advocacy, and then to review some practical strategies that you can take with you and to your next visits, and then to share some resources with you to use and that are free. So how do we help you be heard as a person who has a story, who has relationships, who's got a career, who is involved in the community, How do we help you keep your voice as not just, as I said, a person with this ALS, but a spouse or parent, a brother, a banker, an artist, a musician. When we write in our notes in the medical chart, we used to write, this is a 66-year-old gentleman with this kinds of diseases, heart failure and cancer and this and that. And we're trying to change the landscape where we say, this is a 66-year-old banker who has 6 children and 3 pets, and also happens to have these diseases, because what comes first is who you are. So there's questions and things to think about, and sometimes you don't know where to begin. So we thought we'd share with you a few ideas of questions that can help you in each category of topics. There are general questions, and sometimes you don't know the answer to these right away. So, hopefully us bringing this up today also might help you start to think about this for yourself and help to formulate, even just for your own identity, what is important to you. Some of the general questions to consider are, when you're talking about your medical care with the healthcare team, how much do you want to know? Do you want to know everything? Do you want to know some things? Do you want to know nothing? And wanting to know nothing is totally okay, but then you have to think about who is going to know the things for you on your behalf. And then sometimes you want to think about, even when you want to know everything and something and nothing, you want to think about the timing of that. Do you want to know it all at once? Do you want to know it in small pieces? Sometimes I ask patients to tell me if they want to know it as I'm finding out, even if I don't know how to piece it all together just yet. Does it give them peace of mind just to know that the test is back and it shows something, but I don't exactly know how that fits into their disease just yet? Or do you want me to wait until I know that so that I can help make sense of it when I tell you that information? Who else needs to know? Who else do you feel like should know this information? What should your doctor know about you? Meaning, what is it that's important to you about you that you want them to understand? So when they're coming up with a healthcare plan with you, it's consistent with who you are. And then regarding your disease, maybe you want to ask things like, how effective is the treatment? How will it affect the things that are important to you? Like, I still want to, work, and I need to be able to physically go to work every day. So, what can I expect, for example? And then symptoms or side effects. So knowing what your symptoms are and the side effects is it's not complaining. And I know that I will be the first to admit that I know sometimes when you'll see written, or you hear doctors will say, the old phrasing is, what's her chief complaint, or what are they complaining of today? And that sounds kind of not great. It sounds like it's you being not nice. But really that's old language. It's chief concern, or what are the impacts of this disease on you and your family, right? So if we don't know what symptoms and side effects you're experiencing, maybe it's from a drug, or maybe it's just from the disease progressing, we won't know how to help. And importantly, sometimes I've had patients or care partners say, well, they didn't really want to bring it up because they were not wanting to disappoint their care team, that, this isn't working, you're feeling quite aligned and you really want to be hopeful together that this thing is going to work. And if you tell them it's not working, then they might be disappointed too. And I can reassure you that that's certainly, we're disappointed with you, not at you. Untreated symptoms or side effects can drain you physically and emotionally. And so, it's the only way for us to know what's going on is if you tell us. And that can be anything, thinking about little things that may not seem obvious. It's not just pain, but, I feel tearful, I can't swallow, this kind of examples here at the bottom. Maybe there's a treatment, maybe there's not, but at least we're in this journey together and we're talking. And as you know, of course, the decisions and the conversations and ALS it affects more than just the person with the disease, right? It affects your whole family and your care partners and the people who love you and your community And so as you think about these questions, you also probably want to think about questions about how it's going to affect those people. How will the treatment plan affect those people in my life? What will my care partners need to know or be prepared for? So thinking about yourself and then thinking about how it's going to, how that ripple effect will expand outward. Next few slides, I think Dr. Makowski is going to take over for us.
Right. So, there's a lot of discussion in ALS clinics, and I know that some of you also don't have full comprehensive ALS clinics around some of the technology that's out there and the different possibility of voice banking and about, a lot of people end up talking to their lawyers about who's going to do my will and estate planning and that kind of thing. But one of the pieces that can be hard to navigate, partly because of what kind of the monsters under the bed, is who do we talk to, or how do we start opening up the conversations of the topics that keep us awake at night, the elephant in the room. And the elephant in the room can be a whole range of things, from people are looking at me differently now because I work with Ron Hoffman from Compassionate Care ALS, and one of the stories that really strikes me and reminds me all the time about this illness is how he started in this whole venture with his boss, who worked in the food industry. And when he started slurring his speech, he asked Ron to help him drive so that if he was pulled over, the police wouldn't think that he was drunk. And so even things like slurred speech, how do people see me differently, and how am I going to get through this? And how am I heard as a human being, not as someone with a disability that I've never lived with before? So some of the conversations are, recognizing that friends and family don't know how, or don't want to talk about what's happening. How do you broach that conversation? To also, how do we broach some of the conversations that terrify us? And again, I love what you said, Dr. Mehta, about the timing, because sometimes one of the things that palliative care docs generally are good about, and also chaplains and some social workers are particularly skilled at, is when you say, there's some topics that I'm afraid of thinking about or talking about, and I'm not really ready to talk about them yet, but they're there. There's some clinicians and some people on your healthcare team, as well as friends and families and different organizations, that can help you navigate the timing about when you feel safe and when you have the trust to start broaching the elephant in the room that is keeping you up at night. Through this whole thing, again, is how do you make sure that you can keep your voice as a person, a spouse, a parent, a brother, a creative, a gardener, a banker, a birder, an artist, a musician, a pragmatist, especially as especially as you're seen differently, or your voice slows down, or you lose your ability to be physically heard and it takes longer to communicate. So all of these things, the earlier we have some of these conversations with the people that we trust around what matters most to us, the better it is. Now, a couple little pragmatic things, and these are in healthcare and in life, we have things that are check boxes that are not fun to do, but really help us. Like, we have to pay taxes at a certain time. We have to fill out certain paperwork that we need to a certain time. And really, every adult should have a healthcare proxy or a healthcare agent identified, no matter whether you're healthy or not. So understanding who can you trust to talk to and advocate on your behalf, who will honor your story and your values, that might be your spouse, but for a lot of people is someone who isn't your spouse. So figuring out who that person is something that all of us should have that document done. And then I think we will go into I'd like to move forward on some of the other pieces before we go into the details about the serious illness conversation. The key thing around this, though, is any of these talks that are hard for us to have, the earlier we start having those conversations, the way that we can hope for the best and plan for everything else. I like the analogy of, in the North, I live in Rochester, New York, which isn't far from Buffalo, and we get lake effect snow, that we like to buy snow shovels when they're on sale, in the spring or early fall, when no one's thinking about a storm, because then we're prepared. And it doesn't mean that we want the snowfall to come soon. We don't want a storm to come. We don't want winter to start. And buying that snow shovel is not going to change the date of when that storm comes. But it gives us peace of mind that we're prepared for it. And so figuring out a way of honoring your preparedness, but having some of these conversations when we're not in the middle of the storm, helps us be prepared for when that storm comes. Having a flashlight just in case we lose electricity. All those things can be really helpful, and serious illness conversations can help in that, help our families and ourselves know how to proceed should there be a crisis or when that crisis might occur. So in terms of, why this can be particularly helpful, by opening up these conversations with one another, and I'm going to take a step back for a moment, because it's not only having these conversations, but how. And I'm going to take a step back about the way that I invite some of these conversations in. I think of the conversation, if you think about a diagnosis like ALS, my brother was in the movie industry, and one of my dear colleagues, he's a playwright or movie writer, as well as a palliative care doc. And he talks about, if you think of a movie, any good movie or any good play or any good book, if you think of the 3-act or 5-act structure, it starts off with life as we know it. And then act 2 is life turned upside down. And this is what ALS does. We have life as we know it, and then life is turned upside down. And then the next act, however long that might be, and it could be 3 acts, it could be, it could be a 5-act play and we're in act 2. It could be a 3-act play and we're in act 2. But what this conversation does, it allows you as protagonist in the story to help define how your story is told and how it unfolds. And so by having the conversation with people that you trust, it can decrease stress of the people that, often it can decrease the stress and worry from your care partners. And also it helps you lead the story with your clinicians. It helps relationships. It helps improve understanding. Doing a lot of inquiry around your diagnosis and what it means. And so that's where some of this can take place. Okay, next. From the standpoint of clinicians, as a physician who hears these stories, and I'll give you an example. When I worked at UMass, we had a tool, an online tool that helped people facilitate some of these discussions. And there are some great tools like 5 Wishes and Conversation Project that are out there that help guide people around how to have some of these conversations. And I was called in to meet a patient, not with ALS, but another serious illness, on a Friday afternoon, about half an hour before they were going home. And we planned on a clinic meeting the following Monday, but I couldn't have the full conversation because the ambulance was coming to pick them up. So we pointed them in the direction of some of these tools and encouraged them, if they wanted to explore one of these tools with their family. And what that did was open up an opportunity for the person who was diagnosed with this illness, the people who they loved, to support each other through a time in life that is, that was frightening, and address with compassion each other's concerns and hopes, as well as possibilities and dreams. And so some of the questions aren't just what do I want medically, but what matters to me in my life. And some of the stories that have emerged from this, when this person came to the clinic on Monday, the engagement and the relationship with that physician, they were able to drive the boat because they had thought about it, and they had figured out through this conversation with family how to take their values and their story and interpret it into kind of a clinical language, which really took away some of the emotional distress of having that conversation. So it eases that relationship, not only for you, but for the clinician that's guiding it. And it can humanize some of the conversations dramatically. So, in terms of thinking through what matters most, and I like to ask some people, what are your non-negotiables, and what are you hoping is possible? And so again, this comes into two places. Like I know a lot of people who say, I want to hope for a reversal. I want to hope for being the lucky person on a clinical trial who gets something that really turns this around for me, and I'm going to hold on to that hope. And at the same time, these are my non-negotiables. These are the things that really matter to me and my family. So we can always hope for the best while preparing for other things. And the non-negotiables would include things like, I want to make sure that I can communicate as well as possible with my family for as long as possible, as long as I can. So support with communication is going to be really important for me. Or, there's stories of people who've written books, or, you've heard this on the news and through stories of people who've done a lot of amazing things. How do I handle finances? How do I get my needs met? If I'm a person who lives alone, how am I going to get my needs met and maintain my independence for as long as possible? So all these different aspects. And the key thing, the fundamental thing is physicians and clinicians are going to ask you a lot of the medical pieces that we need to catch up on. Fundamental to all of this is, just like Dr. Mehta said, is your personhood or your personhood. What gives me my sense of meaning and purpose? What are the roles and relationships that are most important in my life? What are the values, and how do I want my sense of purpose, my life story to be told and held on to? What is the legacy that I want to leave? What are the hobbies and what gives me joy? One person who I know who's living with PLS, kind of similar to ALS, goes and takes horseback riding lessons and was able to participate in some events, including rock climbing for people with disability and ALS, or someone else who is an avid birder has figured out how to, we're helping them think through, this is really important to me. So what is possible to help me continue getting out into nature and enjoy these things that matter to me? So all of this in terms of what matters most helps inform the story. It's not just what medically do you want or not want done, but what is important and what is possible despite my changing functional status.
Thanks, Dr. Makowski. And I'll just add two things to that, if that's okay, which is, I just had a patient this week tell me that she loves to hike, and she, her husband found, when they were going on their trip, he found like wheelchair accessible hiking paths, and she didn't think that she was going to be able to go on any hikes on their trip, but that it was a really nice surprise, and he was able to kind of find that without too much difficulty. So things that just made me think of that just happened this week actually too in clinic.
The person who's the birder who I've met, she's just an inspiration. And she and her husband had just recently retired. And one of the things that they wanted to do was get a camper. So instead of getting a regular camper van, they got a handicap accessible camper van.
Nice.
That allows them, as her disease progressed and as she needed to move from using a walker to a wheelchair, to still be able to go camping and birding with her husband and find those places. So
Exactly.
having that narrative. And, honestly, one of the things that drove me to this specialty in palliative care is the ability to explore what's possible in the face of really horrible, life-changing diagnosis that can sometimes feel like hope is taken away. But instead, if you as a patient are dreaming about possibilities, hopefully we as a clinical team and other support groups out there can help you think through how can we maybe explore the possibility of holding on to these dreams and these values.
Right. And I recognize that, as we talk about hope, there's also grief as you're having to shift from what you could do with a body that didn't have ALS to a body that does. It's going to lead to feelings of both hopefully hope, and hopefully this excitement of how can I reinvent my interests and my hobbies. But there is a side that we recognize of grief and loss, and recognizing that we're holding both with every, with the, you don't have to, most people don't exist without both simultaneously. They come and go and ebb and flow. And we're quite aware of that, and understand that that's, a natural thing.
The other thing the other link to that I want to just allude to is in healthcare, rightly so, medical ethics focuses on the wishes and values of the person who has a diagnosis. With ALS, just like you said, Dr. Mehta, if we're lucky, we're living with people who are going to be part of our care partners, or we have family and friends who are really that are very closely involved in our lives. And if we don't have them, we still have to think about who is our community, wherever that's going to be, in terms of helping to care for us. And having the open conversations with the people who love us, and who are going to be involved in tending to one's needs as functional status changes, is an incredible, generous sign of love, taking into account and having an opportunity to listen to their fears, their hopes, their values, and see how that, where the conflicts and where the overlaps are, so that the support can be there to tend to everybody involved in this journey, this really tough journey.
Yeah. So we want to shift into some more practical considerations. The next few slides will go through things to think about for the conversation. And then after that, Dr. Makowski is going to talk a little bit about, she's going to share with you some actual tangible resources that you could print out and take with you before we wrap up. But these, as we thought about these are really important, because many times oftentimes if there's a healthcare team asking for a conversation, or it kind of comes up sporadically as new information has been shared, right? Sometimes you go to the doctor's office or the clinic, and they come into the room, and then they say, we've got your new readings, or we've done these new testing. They are knowledgeable, aware of the information. You are being on the receiving end of it. So you're not necessarily aware of the results. And in that process of preparing to tell you, the clinicians, the clinical team is preparing for this conversation. None of these conversations are easy for anyone. So preparation and thinking about the information and how we're going to deliver it is really crucial to helping alleviate some of the distress that comes with the act and the process of having this conversation. And so, you know, it is by far, I'm not a huge fan of when I say, well, I know this is difficult for you to hear. It's difficult for me to say, because I think the person suffering the most in this process is the person who's receiving the diagnosis and on the part of living with it. But it is also difficult to share this information. And I think that, you know, we teach communication skills. Dr. Makowski and I did a whole year of fellowship training to learn some of these communication skills because they're so difficult. And I think if we can kind of share how it is that we as clinical teams prepare ourselves, we teach our learners how to prepare themselves, then maybe the hope is that you can prepare the same way for these considerations, because the intention is that you're an equal partner in this conversation. This is a partnership, a conversation that we want to have together. So what I usually recommend thinking about, and what I'm thinking about, is I think about discussions in 3 parts: things to consider in preparation, and then things to physically, practically prepare for that conversation, and then things to think about during the conversation. So I'll go over some of those thoughts with you. So the first is how much do I want to know in this conversation? There should be ideally a series of conversations. So knowing that you don't have to get through everything all at once in this one 30-minute or 60-minute conversation. You might just hear a diagnosis and say, that's it, that's enough, I want to stop there. Or it might leave you with too much anxiety and stress to just stop there, and you may need to know more. You may need a follow-up the next day, for example, versus right all at once. How do I like to talk about difficult things is a good question to ask yourself. Do I want to hear about it directly? Do I want to, hear about it in detail? Do I want big picture? Do I want to start big picture and then narrow in and fill it all in? Or do I really need to be able to look at it step by step and with each step know some of the details? I've literally had patients tell me, please sugarcoat it. I just kind of need to know the best, and I don't want to know the worst. Who else should know? So thinking about, do I want to tell them myself, or do I want the team to tell them for me? Or do I want them to be there at the same time with me when I'm hearing this information? Which means when you're preparing, you want to think about, do I want this person to come with me? Do I want to get them on the phone? Do I want to ask the doctors to call them after they're done talking with me, so that I don't have to relay it, and the timing of that? And then what should my healthcare team know about me as a person? Again, everything that we just talked about, those are things that I would encourage you to prepare for if you know that you're going to either ask for, or if you've asked for a conversation that might be difficult, or if it kind of comes up in that clinical visit that day. These are things that you might be able to prepare ahead of time. I'm going to go see the clinical team tomorrow. I have some questions for them. The next would be thinking about how to actually practically prepare. So one is making a list of questions and concerns, writing it down. I teach my learners that even in preparation for the meetings, they should write down all the questions that they might have and gather the information from beforehand that they might, that might come up in the meeting, right? So if somebody asks me a question, I know that I can always say, I don't know, I will get you that information. but it would be nice to know whatever I can, or to try to preempt, oh, somebody might ask me this. Let me try to see if that information is available, especially if, for example, if I have to talk to somebody else to get that information. And then a list of prioritizing topics to discuss. So you're going to run out of time in that visit sometimes. So you might say, okay, I have 6 things. I want to definitely make sure we get to these 3 things. And then at follow-up visits, I can ask them other questions. You might want to, again, going back to thinking about who do you want to have come with you, request a partner to join you for that meeting. And they might only be able to join, excuse me, by phone. And that would be okay too, or by video. And that's all right. Telling the healthcare team when they come in the door, hold on, I gotta get this person on the phone with me. That's totally fine. And then if you know that you want to have a conversation and your healthcare team isn't expecting it, let them know ahead of time so they can book you in for a little bit longer. Call the office and say, hey, I see I only have a 30-minute appointment. Is it possible for me to make that an hour? Or can I, schedule a separate visit because I just want to talk about this. I just want to focus my entire visit on this conversation. During the conversations, I always encourage people to bring a pen and paper or have their loved one bring some kind of a way to document on their phone, even if they need to keep notes or recording with permission, of course, of your team. And then minimize your distractions. So even for the healthcare clinicians, there's this whole mnemonic of like setting the environment, right? You don't want to be physically uncomfortable. You want your phones turned off or silenced if you can, if it's appropriate. If you're home on a virtual visit, trying to minimize interruptions. I once saw a patient and they were, they couldn't help it, but they had literally had like home construction going on while we were talking, and it was a little disruptive. They shut the door and minimized all that they could. And actually at some point they just asked their loved one, could you ask them to just take a break for like 15, 20 minutes? We're almost, I would like to talk without interruption. You might want to think about, how will I be physically comfortable for the next 30 minutes or so, or maybe even an hour, right? Can I sit in this position? As much as you can preempt it, am I comfortable in my bed? Am I comfortable in my wheelchair? Am I comfortable with this pillow? Let me make sure I have water or let me make sure I can get somebody available to me in case I need to be turned while I'm talking. And then it's okay to ask for any information to be repeated. I've definitely repeated a few times, and I've actually told the person, please forgive me if I've repeated stuff that you remember. And they've said, even if you have, I don't care. I just want to hear it again. Sometimes it's hard to hear the information again. So that's something to just keep in mind. But if you need repetition or clarification or a summary, don't hesitate at any point to ask for that. And sometimes it's good to do a teach back. We also often ask patients, okay, let me make sure I explained that to you clearly and correctly, because I want to make sure that I didn't, I wasn't confusing. And so can you tell me what I told you so that I can clarify anything that I might have misexplained. Those would be things that I would consider during the conversation itself. All right, so Dr. Makowski is going to take us home with these last few slides.
Okay, so just like you said, Dr. Mehta, especially learners, we encourage that they'll sometimes create notes or cheat sheets or questions to go into some of these meetings so that they have a guideline on making sure that they're not missing any of the key areas to address. And one of the things that used to drive me crazy was how, as a physician and, my colleagues or learners or whoever, we would be taking notes and we would give a verbal kind of summary of the conversation. And then the patients and families would leave with nothing written down or no, or we're also prepared ahead of time, but people come into our visits and have no guidance as to what's going on. So one of the things that I've sometimes shared with people is a little cheat sheet for them on how to prepare for a visit. So what are my chief concerns? These are especially for follow-ups. How am I feeling today? And, this isn't the how are you doing today question that friends and families ask you, and you want to say, I have ALS, what do you think? Or today's a great, this is really about some of those symptoms, and these are some of the changes that I've had that I'm struggling with. One of the questions that as a physician, I think is really helpful is, our role in many ways are to address your fears and about the things that are preventing you from living life as fully as possible, given what you're physically encountering. So what are you worried about? Not only right now, but also what's keeping you up at night, or what are you worried about that's coming up that I may or may not be able to address? And the reason why that can be helpful is sometimes the worry is grounded and we might be able to help you navigate it. But I've also had people who are worried about something that they encountered on the internet that is not something they have to be worried about. So as a physician, I can say, you know what, that's a really good question, but let's go over why that might not be something that you need to be concerned about, or let's rule that out and make sure that's something that you don't have to be worried about. So actually bringing up some of the things that are causing you to stay awake at night or waking you up at night that are worrying you can really help focus the physician in guiding you. One thing that comes up often in conversations with people living with ALS is how this disease is ever changing. What is true today, I have all the equipment I needed for last week, but now I need more equipment. So I'm having a hard time staying on top of what's coming next. And so having that, if you are a planner, or if you're a caregiver as a planner, and this is what I also see, sometimes it's the care partner or a mother-in-law or a sister who's the planner, so that the person living with ALS is not so much the planner and can focus on the day-to-day. So finding out who is the planner in your care part in your circle, who might want to find out what can I expect and what can I plan for, can be helpful. So that those two questions can really help. And, some of the other questions that came up too is this illness affects people of all sorts of different ages. So what can I help my family prepare for? It might be a parent, it might be a child. And that child could be any age. And so finding out and making sure that your team knows that there are people in your family that you perhaps want some guidance for support with, and your care team might have additional resources for them. And, this other piece is some important things that you as a clinician might want to know about me and my family and my life that could influence care. If there are big life events, or if there are particular values that are really key, all those, or family history that's really important. For example, there are people who have, familial ALS and have seen family members live with this before, live with a trach or not, experience other serious illness, and their different responses and the different choices that they make might influence the way that you make decisions about how you want care to unfold. So those stories can also be very helpful for the clinician to take into consideration. So this is just a useful cheat sheet that you can print out and use as a resource if you'd like. There are some other resources here. The Les Turner Foundation has a communication passport to quality care. And so that's certainly one very useful tool that is available.
Yeah, I'll just comment that it's quite in depth and it's really, really beautifully done. One of the best ones I've seen out there. So highly encourage people to take a look at it. Free, of course. Sorry.
The Conversation Project is not specifically ALS focused, but is very thoughtful And actually, one of the founders of it is someone who has a chaplaincy background. So it really takes into talk about personhood and a conversation that honors the human experience of all of this, and how does one talk to your family, and how do you engage in family conversations around this. This is a very kind guide with a lot of these questions and resources.
This is this is their workbook. Yeah.
So all the resources are right here. There are a number of others. One of, I think, Dr. Mehta's and my favorites is 5 Wishes. And all of these kinds of tools are really useful tools. And if you have them filled out and bring them in, that can really facilitate some of these really challenging conversations that can sometimes, the emotion of it can take away from the interaction. And so by being prepared, it can really help dissipate some of the tenseness of that conversation. So here I just want to quickly articulate some of the differences between these. So we in medicine, and definitely in palliative care, we talk about this global term of advanced directives. What is advanced directives? And advanced directives it's like a medical term. Like it doesn't really mean much in regular English, except it basically is saying, do you have a plan for your future when and if things aren't going well for you medically, right? And so these are the medical components of it that healthcare looks for. Many states look at a living will that tends to be more of it's a legal document that often guides clinicians, but clinicians aren't necessarily bound by, but it guides conversations around this. There's a healthcare power of attorney or healthcare agent or healthcare proxy, depending on the state that you're in. And that paperwork is really important to have. And the reason why that, I would say, if there was one thing that from a medical legal standpoint, is if you're ever in a situation, and this again applies to anyone over 18. So we used to, at UMass Medical School, we had a competition for the medical students to see which group of, they had houses, kind of like in Hogwarts, which house at the medical school had the highest percentage of medical students with healthcare proxies completed. So we wanted our medical students who were in their 20s filling this out. And the reason why is if you're ever in a situation where you can't answer questions for yourself or advocate for yourself about your medical wishes, then depending on the state, if you don't have a designated person through a healthcare proxy, healthcare power of attorney, healthcare delegate, someone who's legally documented to be this person, then there's a window which your next of kin usually can answer those questions. But after that, people will have to go to court in order to have that ability. And so it really helps decrease some of the stress for everyone if you can identify who that is. And on that paper, you don't have to specify anyone, anything except for who you trust to make those decisions. What I would say, though, is having the conversation with that person and making sure they feel comfortable following through on honoring your values is really key. So this is a very useful piece. And then the last couple of things are the medical decisions and healthcare wishes. And, the wishes are around what you're hoping for, but also planning for if things don't go well. What are some of the, again, non-negotiables? What are some of the things that matter most to you then? Go ahead, Dr. Mehta.
Oh, I was just gonna say it's Anne-Marie. I wanted to give you like a 3-minute warning.
Okay. Yep. We're just about finished here. So again, when to have these conversations, a new diagnosis. So if a new diagnosis is to at least say, all right, this is a big diagnosis for me and I need to come in and let's just talk about who is going to be part of my medical decision-making team and what does that mean? And then significant changes. This is when you want to bring this up not only with your personal care team, but also your clinical care team. And then if thoughts are keeping you up at night, or you're really clear about changing direction of care, or things are distressing to you, that's when to call your physician, say, I need the extra 30 minutes, or I need an hour conversation, and you have that right. So Dr. Mehta, I'll let you.
Yes, yeah. So we wanted to thank you so much for doing this with me, Dr. Makowski. I think we, got to our take-home points, which are that, really self-advocacy, and we hope that this helps to convince you that really it helps to ensure that that as a patient, as a care partner, your voices are heard loud and clear, with the intention of ensuring that the needs are met, your needs are met, not just the healthcare teams, and that the conversations will then foster a collaborative approach to care, and that by being an active, engaged participant, which I imagine most people are, but I think sometimes it's a little hard to know how or when or what to ask about, then hopefully this increases your confidence in getting the information across that you need to get across, and to gathering the information that you need in order to live a life that you are, accepting and comfortable, and that gives you a chance of really feeling like there's still more time and there's still more things to enjoy. So with that, we really want to thank you. I think we're at the top of the hour, so I know our discussion is a little bit short. I didn't see any questions in the Q&A or the chat, so I'm hoping that we kind of answered everything. But I know that I will say that for myself, I'd be happy if there's any questions or thoughts afterward that people want to email me. I'd be happy to have Anne-Marie share my email address. But thank you so much for hosting us today and for inviting us to do this.
No,
Yep. Please feel
it
free to, I'm happy to participate in answering questions.
perfect. No, thank you all. I just have one more slide. Anyone who is interested, our next ALS Learning Series is going to take place Thursday, September 19th at 12 p.m. Central Time, where we're going to have Emily Brown from the Patient Advocate Foundation talk about open enrollment. So open enrollment will be starting in October for Medicare. So please come. Also know that it will be recorded. So if you can't make it, you'll be able to find it on our website, or you could email me. I'm happy to send the direct link to you, but that should be up on our website within the next day or two to register for. I'm gonna check the Q&A one more time and it looks empty. But again, anyone, if you have any questions, again, feel free to email me. I'm at adoyle@lesturnerals.org. And I believe my name is, that email address is in the Zoom link, like email that you might have gotten as a reminder. And if I can't answer the question directly, I will absolutely direct you to Dr. Makowski and Dr. Mehta. Thank you all so much for giving me your afternoon today. I really appreciate it. And I hope everybody stays well. Have a good one.